Greetings and welcome to this video module on ICU antifungal strategy. In this video, we'll discuss about the empiric therapy for fungus, then the preemptive therapy, then finally the targeted therapy. So, why should you start the antifungal now before you even know the fungus? So, in cases of ICU setup, patient will be sick and hypotension with angioinvasive funguses causing multi-organ dysfunction, CNS involvement. So in these cases, you must need to know when to start antifungal therapy and what antifungal, and then how to de-escalate to an appropriate antifungal based on the fungus identification. So we'll discuss everything in detail in this video. This is a one-stop video that you need to know when you want to manage a fungal organism in the ICU. Let's get started. So the IC reality, the cultures for these fungus organisms takes a long time. So you must not wait for the cultures to come. The patient can go and crash in matter of few hours to in a day or two. So always start an antifungal when you are in suspicion of a fungal organism. So imaging is often delayed and often non-specific for a fungal infection. So try to not rely on any imaging facilities. And if you suspect and fungus, then treat fungus. Species is usually unknown at the start, so you can go for a broad spectrum therapy that we'll discuss now. So antifungal therapy in ICU must be probabilistic based on the likelihood of what the organism that could be involved in this patient, biology driven. So in that organism, how will it respond to the antifungal that you're giving? And the host driven factors such as the patient is comorbid conditions like diabetes, hypertension, whether it is uncontrolled or controlled, CKD status, post CNS infection with CSF rhinorrhea, nasal sinusitis or other factors. ICU therapy is a strategy based mechanism to prevent the patient from dying and finally getting into the appropriate antifungal of choice for that organism. So it's not just microbiology. We'll just go and get learned about everything in this video. So three distinct ICU approaches. You can go for an empiric therapy, you can go for a preemptive therapy, and go for a targeted therapy. So initially, we never know the organism, no proof of any organism. So in this case, a high clinical suspicion of fungal organisms, and the patient is unstable, go for an higher end antifungal, such as liposomal amphotericin. And for preemptive, you can go for when the risk factors are known, when the biomarkers are available, imaging signals are there. But it's still no, the culture is not yet available. Go for a preemptive therapy targeting that group of organism. And when the organism is identified and susceptibility results are available, go for a targeted therapy. So most ICU mistakes happen by using targeted thinking in empiric situations. So in case of an empiric situation, go for empiric and higher end antifungal. So step zero, the four critical questions that you need to ask before choosing any antifungal therapy for treatment, whether it is an yeast or mold that you are targeting. So based on the site, risk factor, and imaging, you can very well identify whether it can be an yeast or just a mold. So in these cases, whether the patient is stable or unstable dictates the need for a fungicidal speed. So whether you want to use a fungistatic drug or fungicidal drug depends on this. So competent or compromised patient immune status drives the spectrum. So if the patient is immunocompromised, you always need to go for a higher spectrum of antifungal. And if there is feature suggestive of mucor, this single question will change the antifungal of choice. So in case of mucor, you must need to give voriconazole. Even ribosomal amphotericin B is considered inferior for mucormycosis. So empiric choice, suspected sepsis. So for example, a patient is unstable and the most likely organism is Candida. Then finally, the default choice would be Echinocandin. So why? It covers all the Candida species like Candida albicans, Clavarata cruzi, and oris. And it is fungicidal also, leads to rapid killing, safe in renal failure, and effective without waiting for species identification. So in this case, going for an azole therapy is not appropriate because it is just a fungi static drug. So red flags for molds and not Candida. So echinocandin empiric therapy becomes dangerous if molds are likely. So for example, the patient is having prolonged neutropenia, hematological malignancy, or the patient having high dose steroids. In all these cases, these are red flag signs for mold infection. So in these cases, echinocandin becomes dangerous. So because these molds do not rely upon the beta-glucan chain, so it is not responsive. So in the presence of lung nodules, hollow signs, sinus or orbital involvement, black X scar, rapid necrosis, in all these cases also, you must go for an higher end of antifungal and not the echinocandin. So mold likely, so aspergillus versus mucor, that is also you must need to know. Starting voriconazole alone completely misses out the mucorales while treating aspergillus, so it allows mucor to explode. So in that cases, start liposomal amphotericin B. It covers aspergillus, mucor, resistant candida, and buys the critical time. So in these cases, you can go for liposomal amphotericin B. You can always de-escalate later when species is known. So never escalate after mucor declares itself. Pre-emptive therapy, it's not empiricism, so it's evidence-based guided early therapy used when the patient is stable, risk factors are present, and early signs are positive. So typical triggers are positive galactomannan, such as the presence of beta-D-glucan side chain or the aspergillus or the candida infection. So CT chest nodules in neutropenia, colonization rising markers. In these cases, mold active as well can be goes for aspergillus, echinocandins for high risk of candida infections. So in these cases, you can go for targeted therapy. I mean, preemptive therapy when the still the fungal organism is not yet identified. Based on these features, you can typically go for an preemptive therapy. So how targeted therapy is now for candida, step down to ozole if only stable cultures are clear and susceptible. In case of aspergillus, continue mold active azoles only, voriconazole. Switch only for toxicity or resistance. Mucormycosis, do not de-escalate early. Step down only after clinical control is there. So ICU success is decided by appropriate de-escalation and not just escalation of this antifungal. So source control is a silent decider. So physical check, always check for the central line, abdominal collections, surgical check for necrotic tissue, prosthetic material. Persistent fungemia is the source problem until proven otherwise. Antifungal cannot sterilize the hardware. So common ICU errors. So generic fluconazole, measles, Abrata, Cruzi, Auris, and all molds. So don't go for fluconazole in the ICU. Echinocandins over-reliance misses all molds, Streptococcus and mucormycosis. So don't go for echinocandins initially. So voriconazole. So we wait for voriconazole kills aspergillus but allows mucor to explode. So early cessation is also a very big blunder. Patient improved, stop early leads to relapse and resistance of fungus. So final master framework that you must know the taxonomy, whether it is a yeast mold or a dimorphic, whether it is having a cell wall beta-D-glucan or chitin based cell wall or it is capsulated or not, the dependence upon the sterols, ergosterol dependence or not, and the invasiveness, the fast or slow invasiveness of the organisms. So all these four questions also are very important in determining the antifungal of choice. Amphotericin B, direct membrane pores via ergosterol binding, so it is fungicidal, so it creates pores inside the ergosterol membrane. It ignores resistant mechanisms and the wall thickness also, so but the only major disadvantage is the severe toxicity profile. Azoles have uh, have precision inhibits ergosterol synthesis, cytochrome 51. Mostly static oral formulations and deep tissue penetration is there, but it fails in fast molds and is resistant prone. Echinocandins dynamics. So echinocandins target the beta-1,3-D-glucan synthesis, exceptionally safe with very few drug interactions. It is fungicidal for Candida species, but its weakness is activity against capsulated organisms as Cryptococcus or presence of chitin in the cell wall completely makes this drug useless. So in these cases, don't go for echinocandins. Candida logic, Candida albicans, the reference Candida, high ergosterol dependence beta glucan rich cell wall response to all classes of drugs, whereas the Candida tropicalis groups includes tubulensis and kefir, similar to albicans but requires caution in ICU due to rising azole resistance. Biological anchor is that the slow growth and wall vulnerability defines this group's susceptibility profile of Candida. Candida resistance, Cruce never used fluconazole because it is intrinsically resistant to cytochrome 51 because of cytochrome 51 alteration. Whereas Paraceprolis is lower beta glucan content, so echinocandins are weaker, use azoles or amphotericins. Glabrata reduced ergosterol reliance and pumps, so echinocandins are the first line group of choice. Outliers, Candida auris is a very important organism that you must need to know. It is an outbreak organism. It combines pumps, biofilms, enzyme mutations. So azoles completely fine. Echinocandins are the first line. So, Candida lusitaniae is also a very unique variable biology where amphotericin resistance is frequently encountered, requires species directed therapy. Dimorphic, that is an yeast which is mold outside the environment, and behaves like an yeast inside the body. Primary fungi behave as an yeast in humans with slow growth and high ergosterol dependence. So azoles become the most important maintenance therapy. Echinocandins are completely useless, and because it does not depend on the ergosterol cell wall. And amphotericin B is used for induction, severe infections, and CNS disease in all these cases. So molds. So aspergillus, for example, septate hyphae with explosive angioinvasion is there. So fluconazole has zero roles, never used for molds. Oriconazole class because mandatory first line due to cytochrome 51 affinity. So one important exception is that you must need to know is that Aspergillus terreus is frequently resistant to amphotericin B also. So do not assume ampho covers all molds. So amphotericin B does not cover Aspergillus terreus. Mucorales, so it is 100% surgical necessity is there. So when you suspect a mucorale organism, you have to debride it surgically. So aseptate, ribbon-like hyphae is present. Chitin dominant cell walls. So chitin dominance makes echinocandins useless. Aseptate makes all the azoles useless. Reduced ergosterol reliance also makes azoles and echinocandins useless. So in all these cases, only liposomal amphotericin B comes as a savior with immediate surgical surgery and debridement. Mental flow with us is rote learning. So in this case, you have to know when to use, how to approach for a fungal, and how to treat it appropriately, and how you have to decide on the antifungal therapy, targeting it, so and killing it in the ICU. So if it's an yeast that you're suspecting, go for an echinocandin or an azole. So if it is capsulated, stop echinocandin. That is makes it very useless. If it is a mold, stop fluconazole. That makes it useless. If it is chitin cell wall, then only amphotericin works. If it is invasive, fungicidal is often necessary. So the ICU bedside therapy, unknown candida plus sick, go for echinocandin. Aspergillus suspected, go for voriconazole class. When the mucor is suspected, go for amphotericin and surgery that we have already discussed. Why? Cryptococcal CNS infection, amphotericin plus flu cytosine. Antifungal tables are the footprints for fungal biology. So master this biology, master the world of antifungal therapy. The final thing, unstable unknown fungus, that but you are suspecting a fungus, go for echinocandin. When you're suspecting unstable and also a mold is possible, go for liposomal amphotericin B. When you suspect neutropenia and lung nodules is there, go for mold active azole. When the sinus, orbit, and necrosis is present, always go for amphotericin plus or minus surgery. So you must need to understand this concept in order to find the right appropriate drug of choice for the organism that you have in your patient. So, yeah, like this video, do like and subscribe and share it with your friends. If you're new to this channel, do subscribe. Thank you for watching.